Hello and welcome to day 27 of the EKG challenge. This is a fun EKG and I'm excited to talk about a little bit of the anatomy and physiology that we can learn from it. So let's dive into this study. So the first thing that I notice is I have what appears to be a narrow complex rhythm. If I kind of look down here at lead V5 and I just scan through, it's just a rhythm strip, I notice that my QRS complexes are less than 120 milliseconds, so this is a narrow rhythm. I do see what appears to be some P wave activity. There's a P wave there, there's a P wave there. I look and try to figure out, are the P waves driving the rhythm? I'm not so sure, right? We might have a P wave here in front of a QRS, but I don't know, I don't necessarily see any here. It makes me think something's going on. I look at the rate, and I see it's a pretty slow rhythm. I find a QRS that lands on a solid line, and I go 300, 150, 100, 75, 60, 50. This would be around 43, so maybe 48 beats per minute. So that is, we would call that bradycardia, so it's slow. So we have a slow, regular bradycardia with P waves that don't seem to really be lining up. It's a narrow complex rhythm. Worrisome for an escape rhythm. I look to evaluate those atrial P waves, and I do notice that the P waves are upright in lead 1, and they're upright in lead AVF, and remember that tells us that these are coming from the sinus node. Remember the sinus node sits high in the right atrium, and so whenever the sinus node fires off, it goes down to the left, producing P waves that are upright in leads 1 and leads AVF. So I do have sinus P waves marching through the rhythm. However, whenever I look at my AV nodal function, I don't know if I necessarily see any correlation. So I have P waves that are marching through the rhythm. If we find all of our P waves, we've got, let's see, we've got a P wave right here on the ST segment, we've got a P wave here, we've got a P wave here, another P wave that's kind of buried in that QRS, P wave, P wave. And what you're noticing is we have all these P waves that are occurring regularly, and then all these QRSs that are occurring regularly, but the P waves are going faster than the QRSs, so they're not driving the rhythm. This is a complete AV block, or a complete heart block. Remember that in complete heart block, the atrial rate will be regular, and the ventricular rate will be regular, but the ventricular will be slower than the atrial rate, and that's pretty good for a definition of a complete heart block. Now, what is causing this complete heart block? Like everything, we need to continue our algorithm. We can't stop here at the first obvious issue. Next thing we need to do is look at our QRS complex. We said our QRS was narrow. The QRS is upright in lead 1, and it's upright in lead AVF. So that's our QRS axis. That tells me that the QRS is depolarizing down and to the left, which is normal. So we have a normal QRS axis and a narrow complex rhythm. But we know that this is in a complete heart block, so we can infer from all of this, and based on our rate of 48 beats per minute, that this is a QRS that is being generated by the AV junction and getting our nice His-Purkinje depolarization and spread like so. So we would call this a junctional escape. So far we have a complete heart block and a junctional escape. And before we keep going, just by the way, I wanted to just come in and say, if you like the annotated EKGs, I did include a link that I have for my 100 annotated EKG PDF in the description of this video. So if you like that, go check it out. It just came to my mind. So check it out and let me know what you think. You can sign up for it for free, and you can download 100 of these. So now that we've determined that this is a junctional escape rhythm, now we need to go to our QT interval. Essentially, we need to go through our phases of repolarization. The QT interval appears to be okay. We look at, usually what I like to do is I find a QRS, say this one, find another QRS, and we know that midway between the two QRS complexes, our QT, our T wave should terminate. And you can see that the T wave does terminate by the midway point. So the eyeball test is working for this scenario. So we have a normal QT interval. Next thing I'm going to do is I'm going to look for ischemic changes. And the first thing that I notice is in my inferior leads, I appear to have some pretty significant ST segment elevation. So here's my baseline. In lead 2, we've got this ST segment elevation. Lead 3, baseline, ST segment elevation. And lead AVF, ST segment elevation. So that is ST segment elevation in the inferior leads. And the inferior leads represent this region down here, the inferior wall, lead 2, 3, and AVF. So we have ischemia in the inferior leads. So we have an acute ST segment elevation myocardial infarction in the inferior leads. So we call it inferior STEMI. And this is where this lesson becomes much more fun. So we have an inferior STEMI, and we can even get more evidence of that by this reciprocal ST segment depression in the lateral leads. Like AVL's got that nice ST depression. Lead 1 has that nice ST depression. Those are our reciprocal leads here. Leads 1 and AVL are reciprocal to leads 2, 3, and AVF. Right, so that's good kind of localizing features of the ST segment for this inferior wall ischemia. So can we link the inferior STEMI to the complete AV block? And I would say yes. Remember that the right coronary artery usually supplies the inferior wall. And something that the right coronary artery often supplies is the AV node. So right coronary artery supplies the inferior wall as well as the AV node. So if the blood clot that is causing this occlusion is also causing occlusion of the AV nodal blood supply, you can get both an inferior wall STEMI with AV nodal dysfunction. Sometimes that can be complete AV block. It can manifest as other blocks too, but in this case it's manifesting as a complete AV block. So when we put this all together, we have an inferior ST segment elevation myocardial infarction with a complete AV block and junctional escape. So I hope it's a little bit of a good anatomy lesson for you. As we've gone through this 30-day challenge, the goal has been to build on cardiac anatomy and physiology, and I hope this is another opportunity to do that. If you have any questions, throw them down into the comments, and if not, we will see you on day 28 of the EKG challenge. Take care.